Good afternoon, everyone. Welcome to this session titled High Impact Behavioral Science for Strengthening EA Initiatives. This talk will explore how behavioral science can boost the impact and cost effectiveness of certain EA initiatives. Dr. Catherine Thomas is an assistant professor of psychology and of organizational studies at the University of Michigan. She holds a Ph.D. in social psych from Stanford University, a MSc in global mental health from the University of London, and a BA in anthropology from Yale. She designs and evaluates psychological interventions to strengthen initiatives to alleviate poverty and improve well-being globally, often in interdisciplinary teams and with nonprofits and governments. Dr. Samantha Kassirer is a postdoctoral researcher in marketing at the University of Toronto's Rotman School of Management. She received her MS and PhD in management from Northwestern, her MA in social science from the University of Chicago, and her BS in psychology from The Ohio State University. Samantha studies questions that touch on global poverty and inequality and moral psychology. As a reminder, if you have questions for the speakers, you can submit them via the Swap Card app. I'll be selecting a mix of your questions and some prepared ones during the Q&A. We'll also be holding office hours right after this session in the Empire Ballroom West, which is right next door, for continued discussion. Please join me in welcoming Catherine Thomas and Sammy Kassirer to the stage.
Hi, everyone. I'm very excited to be here with all of you. I've been coming to EAGs for a few years, so getting the opportunity to present is super exciting. I'm also going to be starting the talk. You might notice Catherine isn't yet on the stage. I'm going to be opening with a case study of one of my field partners and walk you through what it looks like to apply behavioral science to EA initiatives. And I'm going to try to argue for why this can be impactful, but I'm very curious to hear all of your thoughts. So the field partner that I'm going to use as a case study is called ANCH. ANCH is trying to help reduce infant mortality rates in the Rajasthan area of India. They are a ambitious impact incubated nonprofit, and they also are receiving funding from Founders Pledge and GiveWell. They're only about 2 or 3 years old, and yet they are on the rise as being considered one of the most cost-effective charities in the EA sphere currently. What they're doing is they're bringing kangaroo care to government hospitals and communities around India where there are high rates of low birth weight babies with high risk of mortality. Now, what they're doing is they're using, from the medical literature, this tactic of kangaroo care, which is 8+ hours of skin-to-skin contact for the low birth weight baby, and at least 8 times per day of breastfeeding for the baby. And this is shown to be incredibly impactful at reducing that mortality risk. Now, their current cost effectiveness comes from GiveWell's estimates of the organization, and it's currently expected to be about 13 times as cost effective as GiveWell's benchmark of cash transfers. And the cost effectiveness range per how much it costs to save a life with ANCH's model is, the best guess is about $2,800 US, which is incredibly low. The current most effective charities estimate that it's about $3,600 to save a life. And the scale potential is huge. So when you look at just the rates of infant mortality in low birth weight babies, this is touching on millions of children every single year. And if ANCH's model continues to grow as it is, this has the potential to have just an enormous impact on the world. So you might be wondering, okay, well, if it's one of the most impactful charities that EA could think about, how can behavioral science then have an impact? Well, as I mentioned, the model for ANCH is to bring KMC to hospitals. So what they do is they train nurses on how to teach new mothers to provide KMC to their low birth weight babies and provide them with the resources necessary to do so. And the ideal number of hours, as I mentioned, is 8 hours per day for the first month of life. But we are dealing with humans who are in very trying situations. These mothers just gave birth to a baby they love dearly that they don't know if they're going to live or die. This is a very traumatic experience for each of these individuals. And so the rates of KMC that's happening in the hospitals currently is not at that 8 mark. Overall, for the first month of life, they're estimating that it's between 4 and 5 hours per day. In the hospital, they can get it up to higher rates where they estimate it's closer to about 6, but it's still not hitting the mark where they expect that they can do the most good and save the most lives if mothers are able to get up to that next level. And so Anj came to me asking, how can I increase KMC hours? How can I get mothers to adhere to the advice and get closer to that 8 hours mark? So this was the research question for a series of projects I started working on with Anj. And I'm going to talk through, okay, well, what does it look like now to bring me a behavioral scientist onto the team to help try to solve this problem? So I'm going to walk you through a research plan that I have come up with, inspired by many others who have come before me, and then talk about how does this generalize out to more than just Anj, but EA initiatives at large. So first is asking just a bunch of open-ended questions to the beneficiary pool in what's called a correlational survey. So coming up with what are the major barriers that might be at play that are leading women to not have capacity or ability or desire to engage in the full 8 hours in hospital when they go home. Things like, is there stigma associated with bearing chest in a hospital where there's lots of other people around you? These wards have many different family members, doctors, nurses, other mothers all around. Is that part of the barrier? Do they not think that this is going to be helpful for their baby? Do they believe that KMC can actually help with improving their baby's well-being and ability to live a good life? And then is there capacity? Do they have the ability to actually spend the time on KMC because it is quite time intensive? The second step after getting in the data of, okay, what are the major barriers, is in-person qualitative interviewing. So I flew to Rajasthan, went to a handful of different hospitals, and spent at least an hour with each mother, asking them follow-up questions based off of the results I got from this correlational data. So I found that there wasn't really a stigma present. Mothers were very bought into the KMC model, but there was yet this problem with capacity. They kept saying, it's not possible for me. And so I wanted to get at why. Why is it not possible for these mothers to engage in the kangaroo care practices? And through these interviews, I found 2 different barriers that were happening, one in hospital and one when they go home. In hospital, again, this is an incredibly traumatic experience for so many mothers, and it's not guaranteed that they're going to have the psychosocial support that they need to get through that type of a hardship. Some mothers I spoke with had amazing family support there so that they were never alone and that they had people to lean on when they were struggling. And some mothers I spoke with had no one with them, no phone calls coming in, no one coming into the hospital, maybe their mother-in-law visiting for an hour a day. And I noticed that the mothers who had this community behind them were the ones who had the capacity to spend the 8 hours and do the work they needed to help their babies. But you can't randomize family support. And so one thing I observed in addition to this is that mothers supporting other mothers was this untapped potential of providing psychosocial support to the individuals that Anj was trying to help. And so one of the interventions that we're working on is how do you create cultures of mother to support? There's more I can tell you about the theory behind the interventions I'm developing, but the next step is going into the surveying and piloting for randomized control trials. I don't have time to talk about the second RCT for when they go back home. That's a time poverty issue. Can get into that in the Q&A. But so the second step in the process is, okay, I conducted these in-depth interviews. Now I want to confirm my observations with a wider set of participants, make sure that yes, there is variation in the degree to which people get psychosocial support from families and other mothers, and find that, again, consistent evidence that that's correlated with KMC hours. So that's what we're working on now. And the next steps after that is piloting different scripts to try to increase mother-to-mother support, and then engaging in the randomized control trial where we have the KMC nurses trained to provide these scripts when teaching mothers how to engage in kangaroo care. And the final step is a pre-post test. So then taking Anj's current set of operations, looking at their cost effectiveness, and then adding this new intervention into their model, waiting a series of months, and then seeing what their cost effectiveness is after rolling this out across all their hospitals. So this is leading to just 2 randomized controlled trial studies with this one charity, but the takeaway from this is what I'm hoping can be the helpful tool for EA initiatives wanting to work with behavioral scientists. So this is my behavioral science model that can help charities pinpoint why is a problem happening, use human-focused surveying, qualitative and quantitative, to understand how can we intervene on this barrier, and then developing these interventions. And there are behavioral scientists everywhere who would be so excited to work with you. I myself and Catherine are 2 of them. And I also stuck up a handful of other field partners of mine just to articulate, like, this is something that is a model that can help with solving multitude of problems across many different contexts. And I'm really excited to now bring on Catherine, who's going to talk about a full life cycle of one such type of intervention.
So hi, everyone. It is so lovely to be in a room of such caring and committed people. I dove into EA philosophy about 15 years ago, and since then I've been working in the movement for evidence-based social policy. And 2 questions I've been trying to answer are, first, do people in poverty face psychosocial barriers that hinder them from taking steps out of poverty? And second, if so, how do we address those problems in our anti-poverty initiatives to more effectively and efficiently alleviate poverty? So I want to take you through a project that sought to answer those questions. So this project took place in Niger, a country that's the front line of climate change and one of the lowest income countries globally. So a partnership among the government, the World Bank, and social scientists tested different versions of a national safety net program to see which might most effectively and cost-effectively reduce poverty. And a target of the program was to support women in developing small businesses like the one that you see on the right here. So we wanted to see which program designs would be most effective and cost-effective, and so we compared 3 different variations of the National Safety Net program. And we compared them to the control condition, which was the standard safety net program, providing approximately $40 per month. So we can consider this our counterfactual, or the status quo. All 3 program designs included a core package of economic inputs, so savings, business trainings, and the first design added to that package an unconditional cash transfer of about $300. The second one instead added 2 psychosocial interventions, a community film event and a one-week life skills training. These are the more exploratory, innovative parts of the program, and so I'll tell you a little bit more about those next. And then the full package put it all together. And then we look at effects 1 and 2 years later on consumption as an indicator of poverty, mental health, and a range of other indicators. So what were those 2 psychosocial interventions? They were broadly designed to help build participants' expectations for success in the program, as well as to help them build practical psychosocial skills. So the first was a community event that took place in the evening, where the village was invited and leaders in the village, as well as program participants and anyone they'd like to bring. We showed a film that we had scripted with a local filmmaker. And this depicts the story of Amina, who is a woman who is trying to make a better future for her household, particularly in the face of climate change. So she's shown to make her family more financially secure, and in the process to overcome obstacles, interpersonal obstacles especially, like resistance from her husband for saving, and gaining respect and cooperation from other people in the community. So just to give you a sense of what this actually looked like in practice, I'll play 2 brief clips from the film. The first one shows you the difficult situation that she and her husband are confronting.
Mai gida, haino kul kan cindi deniya. Hay kul sibar mara. Ya kina ga isi ba halir gihin kon zan kai lokol.
Hannika ay gola sabodinga. Ma ay koy galluno. Hambara ay gido nyak fo sinfo kan gido hankara anayda.
Ay wo dai gadu. Aram mai no dama halaran gani aram dirawodin singi. Ay mu koy gadi nyangaya. Hamba gari inge wo isi ganda bari.
agan bai zag mai no gani da hagai bagai gani mo dole an bagai han fo habu ko yan bonde ne kaga saban da wai bagai gongai mage nera ai di mo mago dingo dai inga tikai mo sintin gudwai magi zen ai kwanda habu ai gudwai waga bi zen kwanda habu kalma so sai sintin gudwai da lai zen ga dan kan bugandi alai sintin gudu alman yanga dai
ai sabai.
So after that, Amina is shown to develop a successful business selling BSAP, or hibiscus juice. And then the end of the film shows that she becomes a respected person in her community, and she does this by sharing what she's learned with other women. So I'll show you the clip at the end of the film as well.
Ison kai diare matkago kada. Kenan dirgudu irga da bari barmai irga barbari kenan irsudu sandai irgorara. Wala? Aidu ai goga warau cirare maharote moso arandi arzakadin kai goga du warau cirara ai ga duwa riba kaina din ai ga fai ihinka ai mai yara dan ai asusora ga gisi matakan inne da magabar mai kuru yadin no irhima irbin boda irmu kokari ga da barai barmai to ai sawu aha to ai sawu
And so that's her daughter's face at the very end. But critically, throughout this film, she's shown to get respect and admiration, to strengthen her relationships in the community, rather than strain her relationships as she pursues her livelihood activities and developing them. And that was a really important factor that we had identified in some of the formative research through methods like the ones that Sammy shared, that women's relationship quality, whether they were able to have positive reputations in the community, influenced how much they could have say over their cash and their participation in the program. So this is a carefully scripted film that was designed to meet the psychosocial barriers in this particular cultural context. This film was then followed by a community discussion that prompted the community to consider how the program related to their values and goals, and then to build consensus around supporting women in the program and their success. The second psychosocial intervention was a one-week life skills training adapted from an organization in Benin, and women in these sessions learned skills like goal setting, effective interpersonal communication, problem solving, decision making, and the film was again then used to illustrate these life skills. Okay, so what did we find? We're going to look at the effects of each of the three program designs against the control on household poverty as indicated by consumption at 2 years. So as a very loose benchmark, the line of extreme poverty was defined during this project period as living on $1.90 per person per day. We found that the control group was living on about $1.70 per person per day, and that capital package significantly increased that to about $1.80 per person per day. The size of that cash grant was quite sizable, amounting to about 50% of a person's annual consumption. Now for the psychosocial package that did not include that cash grant, but instead those two psychosocial interventions, we found that it performed just as well, bringing households about up to that line of extreme poverty. And then the full package, which combined all the interventions, showed significantly higher impacts than the control and the capital condition, bringing households up to about $1.95 per person per day. And the one other thing that I want to point out in this graph is that the difference between the blue bar and the yellow bar indicates the marginal benefit of the psychosocial interventions. So the capital versus the full. And the fact that those are statistically different suggests that there was a significant marginal impact of adding those psychosocial interventions. We also measured things like mental health. And there we found that compared to the control, which is set to 0 for this index, that the capital condition significantly increased mental health. So that's an indicator of life satisfaction, depressive symptoms, and a few other measures. The psychosocial condition significantly increased it, as did the capital, as did the full. And the full, again, doing so more significantly than the capital package alone. So now let's look at cost effectiveness. To give you a benchmark, a recent meta-analysis of unconditional cash transfers found that the benefit to cost ratio, i.e. the benefit of increased consumption at the household level to the cost of delivering the program, that ranges from about 0.8 to 1.5 for unconditional cash transfers, where 1 is the break-even point. And we found that the capital package was in that range, being about 1.3. So luckily, the benefits outweigh the costs. However, that psychosocial package was about 3 times that, 2 to 3 times that. Its benefit to cost ratio was 3 to 1. These are some of the larger benefit to cost ratios documented in this literature and multifaceted interventions to date, and the full package fell in between. So that is an example from the anti-poverty space. I also want to note that different interventions, or similar interventions to these that show role models, teach visualization, and goal setting, have been found to improve impacts in multiple domains. So for instance, showing role models role model films has been shown to increase performance on national exams, to increase economic security in Ethiopia. Teaching visualization of specific possible futures has been found to reduce child diarrheal diseases in Kenya and increase entrepreneurial success in Colombia. So I think this is an exciting area of research. And I want to end by sharing the different ways that you can incorporate psychosocial add-ons into existing EA initiatives. They range from short tweaks to program communications to more intensive trainings and workshops. So in between, you could think about adding these films and movies to programs that role model success in the programs and seek to address particular barriers that participants experience. You could run SMS campaigns and chatbots, bring people together to have guided discussions to shift social norms, and then these more intensive trainings and workshops, for instance, on psychosocial skills. Overall, I hope that we've convinced you that behavioral science has the potential to strengthen EA initiatives. Many initiatives, even the highest impact charities, struggle with this last mile problem and the human side of programming. And behavioral science can be used to identify those barriers to impact, and then incorporate the insights via interventions to enhance overall impact, cost effectiveness, and scalability. Thank you for listening, and Sammy and I will be around to answer questions after this. Happy to talk to anyone about them.
Thank you so much, Catherine and Sammy, for that incredible presentation. We now have time for a few questions before we head over to office hours. So first, in your research, what has been some of the most promising marketing strategies that you've seen to increase the effectiveness of certain aid initiatives?
I think that I wouldn't say there's one particular strategy that comes to mind. I think any strategy that actually goes and surveys the individuals that they're trying to target tends to be some of the more effective. And this is something that's quite rare. Mm-hmm. So for example, one of my projects looks at how different degrees of creating interpersonal interactions between givers and receivers can impact recipients. So some people might be familiar with the identifiable victim effect literature. So this is highlighting the existence of an individual beneficiary can increase donations as compared to just providing a statistic or a group of individuals. So some of my research shows that this actually can be a negative experience for beneficiaries. There's anonymity threat. People don't like their personal information being shared, but this is something that wasn't really explored. What was explored was, can this increase donations? And so we have to always think about the supply side. Yes, can we get money coming in, but also the demand side. How are these marketing tactics then impacting the individuals we're trying to help, the clients? And so I know it's kind of a catch-all answer, but I think incorporating in feedback from the beneficiaries is the critical piece to having successful marketing strategies.
And the thing that I hope that aid initiatives do is shift away from nomenclature of the poor, beneficiaries, passive recipients, and instead talk about people as empowered agents that you want them to be. And I've shown, at least in lab studies, that talking about people as needy, vulnerable, and implying that they're helpless or have a low social position has worse impacts on indicators of empowerment, worse impacts on stigma, worse impacts on self-efficacy than talking about them as empowered agents who have the potential to contribute to their communities and their families. So I think that is a relatively accessible action that EA initiatives could take.
Yeah, definitely. What would you both like to see more people researching when it comes to the intersection of EA and behavioral science?
I think that my big question that I like to explore is what I think Catherine talked about in the last slide, which are last mile problems. So these are any contexts where there is a resource on the ground available for eligible individuals, and there's lower adherence than what could otherwise be helpful. So ANCH was just one example. This is advice, is the aid that's being delivered of how to care for your low birth weight baby. And as I showed with the statistics, it was about half of what is the medical recommendation. And so trying to understand why is this last mile happening, the last mile being take up, like, are people going to choose to use what you're providing? And sometimes aid is not beneficial, and that should tell us we need to tweak what we're delivering or change what we're delivering. It's always useful feedback, but trying to understand, again, in what context are people not interacting with organizations as the organizations would ideally like, and how can we intervene by using their voices to inform the organizational structures.
And just to pick up on next point in the last presentation, I think actually measuring recipients' dignity and their agency in the process of giving aid, not just the outcomes. If you want to ultimately influence well-being and welfare, then we should be thinking about the process of aid as well.
Absolutely. We were just having a conversation on the difference between quality and quantity, where I think a lot of organizations try to impact quantity of years lived or quantity of individuals supported, not necessarily the quality of life people have after interacting with the organization. And I think that's where a lot of the work that we do can come in.
For sure. Well, I think that's all we have time for. But for those of you who want to continue the conversation, Catherine and Sammy will be available for office hours right next door in the Empire Ballroom West. Thank you all for attending, and thank you to Catherine and Sammy for their talk.
Thanks for having us.